All right, guys, we have a 63-year-old female with who presents with shortness of breath. She has a history of COPD, FEV1 68% of predicted, which is treated with albuterol on an as-need basis. Infrequent symptoms last 6 months consisted of dyspnea while walking uphill, but she can walk flat without dyspnea. She now needs albuterol inhaler several times a week. Never had COPD exacerbation. She smoked 45 pack of tobacco and but she quits 4 years ago. No other medical history, no other meds. Everything is normal, but there is wheezing, heard on lung auscultation. What's the next best step? Continue albuterol PRN as she needed, as she is doing right now. She takes it on a PRN. That could be a possible answer because she doesn't really have any major FV1 decrease or any issue like that. Start inhaled tiotropium. Possibly, I wouldn't be against that activity at that. Start inhale Clidion and Valantrol. I think that's a bit too much. I don't think she has that much symptoms that we need to go into that many therapy. Start Mecladion, Valantrol, Fluticasone. Again, I don't think it's that much needed. And between A and B, she has dyspnea only when she walks up the hill. Apart from that, she's good. So like last 6 months, she's been good. We could start something, or we could continue albuterol. What is going to be the answer over here? If I had to choose something, and she's 63-year-old female. FE1 is not that bad. It's 68%. What would I choose over here? Well, I think I'll just go with you know what? She has COPD. Let's be safe. Let's add tiotropium. Let's see what it says. So yes, answer was correct. Start inhale tiotropium. So A, basically we have to look at the education objective. Treat a patient with COPD with long-acting bronchodilators. A long-acting bacterium is recommended in patients with COPD who have mild disease with infrequent symptoms, or in whom the short-acting beta or bronchodilator alone is ineffective. The most appropriate treatment in this patient is long-acting bronchodilators, including tiotropium, LAMA, option A. Option B in our scenario. Appropriate treatment of COPD requires frequent assessment of disease severity. The GOLD Global Initiative of Chronic Obstructive Lung Disease combined assessment stratifies patients into A, B, E based on symptom severity and exacerbation. The goal patient category is determines directs the appropriate pharmacological therapy. Patients in group A, there's is characterized by mild symptoms, one or fewer exacerbations, not require hospitalizations per year. Appropriate therapy includes short or long-acting bronchodilators. A long-acting agent is generally preferred, although patients with mild or infrequent symptoms can be managed with as-needed use of short-acting agents. Both LABA and LAMAs are appropriate choices in the in this patient group. This patient with mild symptoms, modified medical research council dyspnea scale table COPD in this group, in group A, has insufficient symptoms with short-acting bronchodilators. and a long prescribing a long-acting bronchodilator tubulin is the most appropriate step. Although Group A and B indicated low risk, Group B are higher risk of symptom burden. Combined LAMA, LABA therapy, omeclidine, and valenterol are recommended. This patient, however, has only mild symptoms of dyspnea walking up the hill. Monotherapy with inhaled LAMA is the most appropriate option. Okay, we weren't thinking option C. Option where D, we're thinking short and bronchodilators, albuterol are appropriate in COPD as a rescue inhaler, but and for use in patients with mild and frequent symptoms. Most patients with COPD require controlled therapy rather than as a albuterol. This patient, however, has a progressive symptoms, should receive long-acting bronchodilators rather than continuing as needed albuterol alone. All right, guys, anyone COPD, make sure to add your LAMA, so tiotropium or omeclidine, and that'll be very helpful. Thank you guys for watching. We'll see you guys next time.